Thank you for joining us for the 5th Annual Global Summit on Kidney Innovation, If Not Us, Who? And If Not Now, When? A collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Science. My name is Robert Crabtree, and I'm an AAKP member and a kidney transplant recipient. I am a founder of the Road Back to Life, an organization whose mission is to offer hope, education, mentorship to people affected by kidney disease. I was diagnosed with polycystic kidney disease at the age of 12. I tell people I don't really know how I felt about it, but I learned to live with it. And when at that time I was told I wouldn't live to see 50. And that had been the fact in my family. But over time, with technology like what we're talking about now, I had the chance to live, and I got to see my dad go through kidney failure, dialysis, transplant. And so I learned that this whole process was more of a bump in the road than the end of my life. And my dad proved to me that dialysis is meant to give life, not to prevent it. All right. I've been part of AAKP since 2022, and it's allowed me to access the education and resources I needed to improve my quality of life as a patient, and a platform to use my voice and my experiences in a meaningful way to demand more innovation and more choices for myself, others diagnosed with kidney disease, as well as those yet to be diagnosed. In 2019, AAKP announced two major initiatives, AAKP Global and the Decade of the Kidney. AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the necessity to save more lives. We believe that a united patient voice can drive more intelligent alignment of the policy, regulatory, and payment decisions necessary to bring new, safe innovations to patients without undue waiting and needless interference. Across the globe, AAKP is working with patients, medical professionals, researchers, and medical industry allies to address the many unmet needs of the global kidney community. AAKP believes this international collaboration can help close the gaps in the U.S. and in countries where healthcare systems and/or infrastructure do not fully support patient consumer choices or immediate access to new treatments. Today, I am pleased to be the moderator for our session on COVID-19, continued global impacts on vulnerable populations. As a kidney community, we know very well that as a matter of federal government policy, the COVID-19 public health emergency came to an end on May 14th. But as a kidney community, we are also acutely aware of the fact that the COVID-19 virus remains a threat to immunocompromised chronic kidney disease and dialysis patients and immunosuppressed kidney transplant patients. To be clear, AAKP has celebrated the many successes America and other nations have had in the battle against COVID-19. We applaud the fact that the larger population in many countries are returning to work and a way of life that allow them to pursue their aspirations more fully. These achievements and victories over COVID-19 have been made possible by the ingenuity and dedication of researchers, scientists, medical professionals, public servants, pharmaceutical industry workers, and the enormous generosity of American taxpayers and the taxpayers in other nations. However, as patient advocates and allied professionals, we must also remind our government leaders and payers, including health insurance executives, that science and data show today is not a different day for the most vulnerable kidney patients. Our three expert speakers joining us today will touch on these very issues. They are each very strong patient advocates with deep empathy for people in need, and we are honored to have them with us. Joining us first is Dr. Duvuru Geetha. Dr. Geetha is a professor of clinical medicine at Johns Hopkins University School of Medicine. She serves as a consultant for our good friends and allies at the Vasculitis Foundation and as a member of the Miller-Polson Academy of Clinical Excellence at Johns Hopkins. During the COVID-19 pandemic, she was involved in a multi-center study looking at immunosuppressive treatment and outcomes in ANCA vasculitis patients, as well as assessment of vaccine response in immunocompromised vasculitis patients. Please turn your attention to the monitors for Dr. Geetha's presentation.
Good afternoon. I'd like to thank Bob, AAKP, and the George Washington University for inviting me. It's a real honor and privilege for me to be present at the meeting. The COVID-19 pandemic placed considerable strain on healthcare systems and necessitated immediate and rapid alterations in delivery of healthcare. In the past 3 years, we have seen national lockdowns with tightening and relaxation of restrictions in line with the waves of infection. At the start of the pandemic, we relied heavily on non-pharmaceutical interventions to control the spread of infections, while later during the pandemic, effective treatments and vaccines showed promise. Patients with kidney disease faced unique challenges, and we will discuss this in the next 15 minutes. This will be the outline of my talk. I will first discuss the impact of COVID-19 pandemic on patients with kidney disease, then move on to describe challenges, and finally review solutions and innovations for healthcare delivery during the pandemic. I will discuss the impact of the pandemic on the entire spectrum of chronic kidney disease, which includes patients presenting with acute kidney injury, patients with chronic kidney disease, both mediated by immune mechanisms and non-immune mechanisms, dialysis patients, and kidney transplant patients. COVID-19 disproportionately affected patients with kidney disease and posed significant challenges in disease management and impacted the kidney community at various levels. Patients with kidney disease are a high-risk population. They belong to lower socioeconomic status. Patients who are having low socioeconomic status live in overcrowded areas. They have increased exposure to poor sanitation and unhealthy environments. They have limited access to healthy foods and often have restricted access to health care. In addition, patients with kidney disease have multiple comorbidities, and a significant proportion of them belong to minority population. Equity was a major causality of the COVID-19 pandemic. An example early on in the pandemic is scarcity of personal protective equipment, which sometimes resulted in hoarding by countries and also by individuals. A number of factors contributed to this inequity as shown in this slide. At an individual level, the significant contributing factors included race, age, level of education, comorbidities, dialysis modality, transplantation, poverty, and citizenship. At an institution level, important factors were accessibility, capacity and funding, triage and prioritization, and healthcare worker burnout. At a community level, social networks, family support, solidarity, mistrust became many important factors. And at a national level, again, solidarity, income level, leadership, COVID-19 policies, COVID-19 data reporting, all of these were important contributing factors. And at a global level, geography, solidarity, power dynamics and inequity, economics and trade-offs, and misinformation were important contributing factors. Amid sudden illness and death, there was a great hope and inspiration among the researchers as well as medical professionals examining the national response to COVID-19. Their efforts uncovered unique insights that have accelerated treatment innovations, that have led to practice changes, that saved lives and slowed down the national death count. It also addressed issues that existed even before COVID-19. For example, these include barriers to quality care and transplant among underserved communities, lack of treatment care choice modalities in high risk patients on dialysis, and utilization, or even better said, underutilization of palliative care. Now I'll discuss the impact of COVID-19 pandemic on patients with kidney disease. In patients that presented with acute kidney injury, about 30 to 50% of hospitalized patients with COVID-19 developed acute kidney injury, and of those, 20% required dialysis. Acute kidney injury in these patients was associated with increased mortality, and acute kidney injury disproportionately affected Blacks and Hispanics. Now, moving on to chronic kidney disease. Chronic kidney disease conferred increased risk and severity of COVID-19, especially in patients with glomerular disease on immunosuppressive medications. There were repercussions on care delivery. There was postponement of kidney biopsies and vascular access placements. There were delays in initiation of dialysis. Patients with chronic kidney disease during the pandemic suffered greater economic consequences with food insecurity, economic insecurity, and unemployment. There was lack of guidance on management of COVID-19 in CKD patients. There were disparities in vaccine uptake across all stages of chronic kidney disease. Moving on to dialysis patients, the initial efforts centered on safe continuation of dialysis 3 times a week. In certain countries, in a survey, it showed lack of transportation, shortages of staff, possibly personal fear or symptoms contributed to missed treatment in surveyed facilities in Africa, Latin America, Middle East, South Asia, and Southeast Asia. Also, there were concerns about training for home dialysis and longitudinal follow-up of home dialysis patients early on in the pandemic. There were delays in access placement, delays in transplant evaluation and wait listing, and lack of data on therapeutics and vaccine response in dialysis patients. And finally, in kidney transplant patients, initial efforts were focused on strategies to decrease the risk of infection and to continue caring for kidney transplant recipients. There was increased mortality, and it was disproportionately high in minorities and socioeconomically disadvantaged groups. There were concerns about continuing transplant surgeries during the pandemic, and we were also having concerns about evaluating the vaccine response in the transplant population, which is immunosuppressed. Now, moving on to the challenges faced by patients living with kidney disease and the consequences. First, focusing on acute kidney injury. What were the challenges? So, with the increased hospital surges, there was increased demand for dialysis with increasing frequency of acute kidney injury. There were shortages in dialysis solutions, shortages in workforce, and finally, there was lack of safety data for antivirals in patients with severe kidney failure. And what were the consequences? About 35% of the patients who had acute kidney injury ended up having residual chronic kidney disease. Moving on to chronic kidney disease patients, what were the challenges? Again, there were interruptions in care delivery, including consultations, follow-up care, monitoring of labs, performance of kidney biopsies, and AV access surgery. There was disruption in initiation of dialysis. There was lack of data on therapeutics and vaccine efficacy. And as a consequence, there was decline in ESRD incidence and transplantation rates during the pandemic. Moving on to dialysis patients, the immediate challenges were safe transportation to dialysis facilities, safety of in-center dialysis, and screening and cohorting infected patients. There were concerns surrounding home dialysis training, waitlisting for transplant. There was loss of workforce, shortage of PPE and COVID-19 testing equipment, and lack of prioritization for dialysis patients for vaccines. And as a consequence, some patients missed dialysis sessions. There was increased mortality rate among the dialysis patients. Moving on to the kidney transplant patients, the challenges included continuing care for the kidney transplant patients during the pandemic. There was a global decrease in the transplant activity, and there were challenges in evaluating the vaccine response. Consequences included increased mortality of waitlisted patients, an increase in breakthrough infections despite vaccination in kidney transplant recipients. So in this slide, this is taken out from a study which assessed geographic and regional changes in the overall transplant activity shown on the y-axis, which includes living and deceased donor transplant, with respect to the number of COVID-19 deaths per million inhabitants shown on the x-axis. And as you can see, three patterns emerged. The first one, which you see on the left top, is a sharp decrease in organ transplant activity despite a low number of COVID-19 related deaths in Japan, Argentina, and Chile. And the second one is a decrease in organ transplantation concomitant with the incidence of deaths in countries like Norway, Germany, Canada, Portugal, Netherlands, Austria, Hungary, Brazil, France, UK, Spain, Greece, and Finland, and a smaller than decrease in organ transplant activity despite a high number of COVID-19 related deaths as shown in USA, Italy, Switzerland, and Belgium. Most health systems were unprepared or at least underestimated the challenges that the pandemic may pose at the beginning. There was rapid reorganization with formation of multidisciplinary teams to address several components that constitute care from a nephrology service. There was redeployment of physicians and nurses to meet needs. Modifications were made in delivery of intermittent hemodialysis, continuous renal replacement therapy prescription, and there was increased utilization of acute peritoneal dialysis. There were novel methods of dialysate protection. We adopted telemedicine very widely. There was remote monitoring of kidney transplant patients. Access procedures were included as an essential procedure. There was prioritization of immunosuppressed patients for booster vaccine and pre-exposure prophylactic treatments. Strategies were shown to improve vaccine efficacy, and there was finally advocacy to include chronic kidney disease patients in therapeutics and vaccine efficacy. So the pandemic has highlighted the challenges posed by shortage of emergency medical equipment and hospital surges, and identified striking global inequities in care of patients with kidney disease, but has also shown that solidarity is required at all levels, from global governance to the individual patients. And this slide highlights strategies that can be followed for future pandemics. And some of the examples will include digitalization of healthcare, need for authoritative and consistent communication from government, and for hospitalized patients, resource allocation and adoption of urgent start peritoneal dialysis, then psychological resource to patients, advocacy to improve or include kidney patients in clinical trials and prioritize them for treatments as well as vaccines. Also shows the importance of establishing international registries. And finally, monitoring and addressing global disease disparities in care of kidney disease patients is very crucial. Thank you very much for being here, and please feel free to ask me if you have any questions.
Geetha, for such an insightful presentation and ongoing concern for this community. Our next speaker is Dr. Lisa Glasser, AstraZeneca's head of U.S. Medical Affairs for Vaccines and Immune Therapies. She has extensive knowledge and understanding of vaccines across various age platforms, from clinical, commercial, policy, and public health perspectives. We've had the great pleasure to work with Dr. Glasser to raise awareness of new therapeutics that are under consideration for vulnerable people. Please turn your attention to the monitors to learn more about the work Dr. Glasser and her team at AstraZeneca have been doing in the COVID-19 space to advance research and bring therapeutic solutions to individuals who are immunocompromised and immunosuppressed. Welcome, Dr. Glasser.
Hello, everyone, and thank you so much for the opportunity to be here, Robert. Thank you for including me in this very important event for the American Association of Kidney Patients. I'm Lisa Glasser. I head up U.S. Medical Affairs in our Vaccines and Immune Therapies unit at AstraZeneca. Very grateful to be here, although not in person. So I wanted to take a few minutes to speak to you about what AstraZeneca has done and continues to do in support of immunocompromised patients, particularly with respect to COVID-19. We know that the immunocompromised population, who account for millions of Americans, are still facing severe outcomes, hospitalizations from COVID-19, despite being vaccinated and receiving boosters, including transplant recipients who are taking immunosuppressive drugs. The data demonstrate that individuals with kidney disease, kidney transplants, may not mount adequate responses to vaccine, and thus may remain underprotected from COVID and severe manifestations of COVID-19. In 2022, there were a record-breaking 25,000 kidney transplants performed in the United States. So this is between dialysis patients and transplant patients, an ever-growing population. AstraZeneca developed Evusheld, which many of you may be aware of and even have received, a long-acting monoclonal antibody, which was designed to fill a significant unmet need, to protect vulnerable populations, such as the immunocompromised, including the transplant patients who may not respond adequately to COVID-19 vaccination and need additional protection. Evusheld was the only option besides vaccination for pre-exposure prophylaxis for many of these patients who just can't mount an adequate response to vaccine. And indeed, we were able to dose more than 300,000 patients with Evusheld in the United States since we had received emergency use authorization from the FDA. In January of this year, the FDA announced that Evusheld is no longer currently authorized for emergency use based on the prevalence of resistant variants. And at this point, we remain in that situation. AstraZeneca has made a commitment to the immunocompromised patient population, and we know that the need continues for additional protection besides vaccine. And then in that spirit, we have begun, actually, end of last year, a clinical trial to bring another monoclonal antibody that can provide pre-exposure prophylactic protection to these same patients. We know that COVID-19 still, for immunocompromised, despite the fact that perhaps the rest of the population feels they can move on, the immunocompromised still bear an undue burden from COVID-19. To keep up with the evolving variant landscape and to be prepared for future pandemics, we are working hard to develop rapid clinical development and approval pathways to respond in a timely manner. We are paving the way with an innovative immunobridging trial called Supernova to accelerate the access to next generation medicines for COVID for this population. The Supernova trial is ongoing, as I said. It's a pivotal phase 1/3 trial for our next generation long-acting monoclonal antibody called AZD3152. There is public information on this trial, and we can supply you with links to the website specifically devoted for this trial for people who are interested. We recently presented data at the European Congress of Clinical Microbiology and Infectious Disease, also known as ECCMID, showing that AZD3152 is able to neutralize all known and currently circulating variants to this point, including those that are clearly resistant to other COVID mAbs. We do believe that the newest XBB variant, some call it Arcturus or XBB116, AZD3152 should neutralize that with great potency. We are rapidly advancing this clinical trial, and we hope to make AZD3152 available as an option for patients sometime in the second half of 2023, subject to regulatory reviews and trial readouts. We all know that last month, the National Public Health Emergency was declared over. That really means that the immunocompromised community is facing new and complex questions around how to best protect themselves, especially in light of limited therapeutic and treatment options available to neutralize the current variants of concern. Absolutely, vaccines and boosters of vaccine series continue to be the best method to prevent COVID for the general public, and vulnerable populations should still avail themselves of vaccine and boostering as recommended, but they may not mount an adequate response to the vaccines and may still be at risk. In fact, the data is still showing that if infected with COVID-19, immunocompromised patients are more likely to be admitted to the intensive care unit in the hospital compared to non-immunocompromised patients. Although new variants are a normal part of the evolution of this virus, SARS-CoV-2, they can be more aggressive, more transmissible, vaccine resistant, and may cause more severe disease. So it's important for immunocompromised patients, including kidney patients, to make an action plan with their doctor, to take all the recommended prevention options that are available, and to have a plan what to do in the event that nonetheless you still get infected. With that, I'd like to close my remarks. I want to thank everyone in the AAKP for the opportunity to be here, for all the hard work that you do to advocate for this very important patient community. I would also like to let you know that we have been doing some research of our own at AstraZeneca on the burden of COVID-19 in the kidney patient population, particularly those on dialysis. This data, which goes through March of 2022, will imminently be published, may even be published on the day of this meeting. But as I'm recording this, I don't have much more to tell you other than this data is coming out. And as soon as we have a link to the publication to share with you, we will do that. Again, thank you so much for the opportunity to be here and for all that you do.
Dr. Glasser, thank you for your work and AstraZeneca's commitment to the community, the kidney community. We'd now like to introduce our final speaker, Dr. Helen Ashuntantang. Dr. Ashuntantang is a clinical care senior medical science liaison working with bioMérieux. Prior to bioMérieux, Dr. Ashuntantang was a pharmacy provider with San Carlos Apache Healthcare, where she assumed many roles. At San Carlos, she started and ran the opioid stewardship program, pharmacist-run hepatitis C clinic, renal pharmacy program, and the medication therapy management program, as well as co-hosting a radio show for 2 years focused on varying health issues facing the community. As a public health pharmacist, she understands the need for health education and a powerful tool for disease prevention and management. Please welcome Dr. Ashuntantang to the podium to discuss the importance of continued research and innovation so those at high risk for severe complications of COVID are provided with diagnostics and therapeutics that will allow them to re-engage in society safely and pursue their aspirations. Dr. Ashuntantang, we appreciate you being with us to share the work you are doing with bioMérieux as it relates to COVID-19. Thank you so much.
Thank you all for having me here. I'm really, really excited to be here. And thank you for those who are here in person and remotely. That one thing that I can tell is that we're all family, a family that loves the kidneys. And for that, I'll say I love you with all my kidneys. I know I don't have much time, so I'm gonna do like a drive-through kind of session here. And I'm just gonna talk about the continuing impact of COVID-19 on kidney patient population. And so I just have a disclaimer out there for you to see. I was not paid for this, so just putting it out there. And I am employed by bioMérieux, as the moderator just said. And pretty much I'm just going to just go over quickly what I'm going to talk about today. Just a brief review of acute kidney injury, which I'm going to refer to as AKI, short and long-term effects of AKI, acute kidney injury in the presence of COVID-19, and the effect of COVID-19 in chronic kidney disease, dialysis and kidney transplant in children, and some of the issues with treatment, vaccination, and care, and why we should be concerned. I know in May of this year, the WHO did announce that the pandemic was over. Not that COVID-19 was eradicated. The pandemic was over, just meaning that it's no longer a global health emergency. Is that true? It may be for the general population, but it's not over for certain populations. And that is the case with the kidney patient population. The questions become, why? So I'm just gonna do like a brief overview, as stated earlier. So what are some of the high-risk factors of COVID-19 complications? Age, so older age, persons who belong to racial and ethnic minority groups, persons with CKD or chronic kidney disease, diabetes, chronic lung disease, asthma, hypertension, and the list goes on and on. And I want to draw your attention to these high-risk factors. It is important to note that most of these factors are the same factors that put someone at risk for CKD. So your average patient with CKD is of an older age, belongs to racial and ethnic minority group, has diabetes. So what are the chances of developing a complication from COVID-19? So what are these complications we're talking about? Here I have listed, in the interest of time, I'm not gonna read them all, but I have acute kidney injury highlighted in red. That's the one that concerns the kidney, and that's what I want to focus on today. Acute kidney injury, what is it, and why should we care? So acute kidney injury, or AKI, is a sudden decline in kidney function. Here, I just want you to look at the influences on the outcome for AKI. If you look, you can see where I have CKD, DM for diabetes, and age. Those are all factors that would increase your risk of developing AKI. Unfortunately, coincidentally, those are the same factors that worsens your outcome when you get AKI. So you can see it just goes in circles, and somehow the patient with a kidney disease is trapped in all of this. Here I'm just showing you a continuum of AKI, AKD, and CKD. Another reason for you to care. When you're exposed to an insult or some kind of injury, COVID-19, nephrotoxic drug, your kidney is stressed. If there's nothing that is done, no intervention, it doesn't resolve, it becomes AKI. After 7 days, if it doesn't resolve, it becomes AKD, or acute kidney disease. If nothing is done, it becomes, after 90 days, it becomes CKD. So you can see that if nothing is done to AKI, it progresses to CKD. And this just shows you the burden of acute kidney injury as you go from subclinical, so from mild to severe. Everything worsens. Risk of non-recovery, short and long-term complications, mortality, and healthcare costs. It all increases as you go from mild to severe AKI. So now that we know all about AKI, and well, not really all. There's more to AKI than this. This is an abridged version. So let's look at AKI and COVID-19. Should we really care? Is it that much of a concern? Yes, it is. There's so many publications out there. There's so many reports from so many hospitals. I just singled one ad just to drive the point home. Here's a Canadian study which they looked at 815 patients who came into the hospital with COVID-19. Of the 815, 439 of them developed AKI. That's a high number. The odds of ICU admission, mechanical ventilation, and death increased as the AKI stage worsened. And the stage 3 AKI, which is severe AKI, during hospitalization, also it did increase the odds of death. So we can see here that AKI is actually more common in patients with COVID-19 than we may think. So we have patients who came into the hospital without any kidney problems, living with kidney problems, adding to the already large population that we have. We saw someone mention 850 million patients in the world. When you have COVID, there's a chance that you may add to that number. So here, I clicked it too fast, but the slide was just talking about COVID-19 in AKI. Is it really a thing? Yes, it is. It just talking about the high rate of AKI that was noticed in patients with COVID-19. And the AKI was associated with pre-existing CKD. Here, the slide is just showing you the relationship between COVID-19 and AKI, or the effect of COVID-19 in dialysis and kidney transplant recipients. In a study that was done in UK, it showed that patients on dialysis and recipients of a solid organ transplant had a 3.5 times fold of death from COVID-19 than individuals without a transplant or on dialysis. About 20% of patients on dialysis died within 1 month of the SARS-CoV-2 infection, higher than the risk of death associated with other infections or many cardiovascular events. Children, we often overlook children. They're young, they're healthy. It's true that a lot of times children are not as affected as compared to adults. However, we did have children who had COVID, and a study that was done in Istanbul showed that compared 71 children with COVID-19 to otherwise healthy children. And what they found out was the children with COVID-19, though it was mild or moderate, they were at high risk of developing AKI. So we need to pay more attention to children. Now, these are children who did not have kidney problems before. So let's just imagine what happened to the children with existing kidney problems with COVID-19. This is a special subpopulation within the kidney disease population that we need to pay attention to. And so I have a slide just for them on what we can do. More safe and effective strategies to include children in clinical trials and studies. We need data on long COVID complications in children. More data is needed on vaccine and therapeutic response in children with CKD. So pandemic is over, but we still have these problems that is lingering around for some. So we may ask the question, okay, so we know that AKI does happen. Can we just fix it? Well, here's what we have at the moment with regards to managing AKI. There's really no therapy to date that has shown efficacy in treating AKI. Fortunately, there's a lot of studies that are going on. Normally, you want to identify the etiology and treat the underlying cause, optimize hemodynamics parameters, identify ways to identify a patient at risk for AKI. And here's where bioMérieux comes in. We're looking at ways, risk assessment tools to identify a kidney that's stressed, so intervention can be done earlier to prevent progression. There are other studies that are out there that are looking at urine biomarkers, AI models. If we can identify a kidney at risk for AKI sooner, we can intervene sooner and we can prevent progression to possibly renal replacement therapy. Another option is to identify and aggressively treat the infection. In the case of COVID-19, so when we identify that it's COVID-19, then what for the kidney patient population? We've heard a lot about restricted access to intensive care. Most low-income or medium-income countries already have issues with access to intensive care. Mechanical ventilation and in-hospital hemodialysis, shortage, lack of access, and you find that a lot in low and middle-income countries. We hear a lot about impaired response to vaccine. Studies have shown, like the RECOVAC immune response study that was done, it showed that patients with kidney disease have an impaired response to vaccine, especially those with kidney transplant. So while others can take the vaccine and walk around freely, we have kidney patients who have fear of going out, going to work, because they're not sure if the vaccine is going to work well for them for protection. We need more safe and effective strategies to include kidney patients in clinical trials and studies. A lot of times, we don't have the number to come up with a concrete result that we can really count on. And with that, kidney patients, we all have to play our role by trying to enroll in clinical trials. We need patients to participate in this study so we can come up with better results. The lack of data on therapeutics and vaccine response in CKD or end-stage renal disease population. I know we had remdesivir, it's out there, and somebody will say, how about that? Why can't we use that? Yes, it's been used, but it is not indicated for someone with a GFR of less than 30. There's a possible side effect, renal side effect, so it doesn't make it suitable for a kidney patient. Then we have Paxlovid. Everybody is excited. Paxlovid works, but it's not indicated for CKD patients stage 4 and stage 5. So what do? So you can see here some of the issues that patients with kidney disease still experience, despite the advances that have been made. And I know we just heard about kidney care, but I just wanted to show this slide. This was published by ISN. It's just a summary that came from India showing the effect of COVID pandemic on the care of patients with kidney disease in India. If you see here, it talked about 28% missed more than one dialysis session. 2.74% required emergency dialysis. About 4 stopped reporting for dialysis. Then there was death. Decrease in outpatient services, decrease in inpatient services, and much more. What is more important that I want us to take a look at is the bottom part, which is the conclusion. It says lack of preparedness. So this is what they got out of the experience. Lack of preparedness before lockdown resulted in an interruption in healthcare services and posed an immediate adverse effect on the outcome of dialysis and kidney disease patients in India. That conclusion right there doesn't only hold true for India. It holds true everywhere in the world. Lack of preparedness. Are we prepared? Do we want to wait until the next pandemic to figure out what we have to do with the kidney patient? Or do we want to act now? It says lack of preparedness. Who is responsible? Lack of preparedness by who? It's us. All of us. Not just the kidney patient, the government, hospitals, clinics, providers, industries, diagnostics, pharma, professional organizations who make guidelines. All of us together, it's a teamwork. We have to come together to make sure we prepare better for the future and find ways to solve the problems that we have now. We, all of us, because now is all there is. And as the theme says, if we don't do it now, then when? And if not us, then who? Thank you so much for the opportunity, and I hope that when we come back next time, we're not talking about the same things. We're talking about progress, where we've moved past where we are today. Thank you all, and remain blessed.
Wow. Yeah. Thank you again to all our session speakers. This was an excellent and informative session.